right. Good morning, everybody. We are going to start the next session. Dr. Stefan will take over. Dr. Panchbhavi will be joining shortly. Stefan, it's all yours.
Hello. Thank you, and good morning from Germany. It's 2 p.m. here, and hope the slides are visible to everyone. Parekh, Selene, is it there?
Yeah. Yep, you're good to go.
Okay, so first a disclaimer. When Vinod asked me about this session, he asked if I do a lot of arthroscopy and ankle fractures. I had to say I do this very rarely. So for those you looking towards a scoping lecture, it's probably a good time to have a coffee or go to the loo. But I hope I can bring you some modern aspects on ankle fracture treatment too. So first of all, hats off to Selene for having this project going and staying up all time. So he combines the wisdom of America and India, and we in Europe we are somehow stuck in the middle and have to see how we catch up. So with ankle fractures, so trimalleolar fractures, the posterolaris, there have been considerable changes over the last years or decades regarding the importance of it. And so nowadays everybody would agree that those 1/3 or 1/4 rule has been let to rest long ago, and that there's more to it than just the restraint for the talus and posterolaris fractures. And so they contribute to bony syndesmotic stability, to the integrity of the tibial incisura, and of course also, depending on the fracture pattern, to the congruity of the posterior plafond. And some are inclined to call some of these fractures posterior pilon fractures. And this is what happens if they are treated in a rather, I would say, old-fashioned way with indirect reduction, more or less a reduction, and not very stable fixation. If the posterolaris is not in place, then the fibula doesn't know where to go. Probably if the fragment goes up, the talus is shifting out of the way, and so the whole ankle mortise is incongruent and has to be corrected directly from the back. So everybody has agreed on that, and meanwhile a bit more sophisticated systems have been elaborated on when and how to treat them. So our preference is to treat them even if they are smaller in size, if they're displaced, and particularly if they have intercalary fragments or depressions of the joint. And so why add another malleolus to this picture? So there is nothing new. The term trimalleolar fractures is quite old, but the idea that all the 4 pillars of the ankle joint can fracture and can get unstable stems back to the 19th century. So it was in the works of Theo, after whom the anterior tibial tubercle is named, and also Chaput, which is the other guy giving his name to that and producing wonderful images in his textbook from 1907, shortly after the advent of X-rays. And it was a Dutch guy who already called the anterior tibial tubercle a 4th malleolus. And I was amazed even to find one article that is written in Czech that's called quadrimalleolar shank fractures, but in fact this person described one ankle fracture with fracture of all the 4 pillars or malleoli. And so if displaced and unstable, they should probably all be addressed. And I'm not the only one with those ideas. So our friends from Argentina, they get their inspirations from other things than philosophy, but it's also a great thing. And so they already also have that concept of 360-degree treatment of those injuries, and to tailor the treatment individually to all the 4 corners of the ankle. And as you can see here, they regard not only the Chaput fragment, they also regard the Wagstaff or Lefort fragments, or anterior avulsions of the syndesmosis from the fibula, as equivalent and worth watching. So why care about the anterior malleolus? Why even call it a malleolus? Well, I think it has a lot of common with the posterior malleolus. It contributes to syndesmotic stability. It's the insertion of the anterior tibiofibular ligament. Some call it the anterior inferior tibiofibular ligament, which does not make much sense because there's no superior one, but maybe it's good to distinguish it from the lateral ligament, which also is called the ATFL. So it contributes to integrity of the incisura depending on the size. So that's another analogy to the posterior malleolus. And thus it alleviates fibular reduction or makes it impossible if it's not there, as you can see in this example here. And then, of course, depending on the size and the displacement of the fragment, it also contributes to joint congruity. And as the posterior malleolus acts as a posterior restraint, the antemalleolus probably acts as an anterior restraint for the talus. So here you can see how this was corrected. And it hasn't been since long that people who looked at CT scans after malleolar fracture that probably didn't go the way they should go. And in several studies, it was found that probably the anterior ligament avulsions or fractures of the anterior rim of the tibia are the most frequently overlooked fractures around the ankle in plain radiographs. Probably because of that overlap between tibia and fibula, which is normal in most ankles. These fragments are not so nicely seen. But as you can also see in this example, how correction of the anterior malleolus also leads to a correction of the fibular position and to a realignment of the ankle mortise. Here's another case example. Active 53-year-old woman, otherwise healthy, twisted her foot while running. So the soft tissues were okay. This was not a very high energy injury, no comorbidities. And since the OR was free, she was taken directly to the OR. The fibular fracture was fixed with a rather long plate and some cerclage wires because it was multifragmentary. The medial malleolus was fixed, and then the syndesmosis was fixed with a screw. The ankle, the anterolateral part of the ankle was not exposed during surgery. So the surgeons were quite positive that they fixed the fibula in the correct position. And when you look at the post-op images and with the image intensifier, it looks like that. But there's nothing worse than a post-op CT scan for the surgeon, but maybe not so much for the patient. And here you can see that it's not as perfect as it might look in the images. So you see, first of all, the medial malleolus has a small step off. It's maybe a little more than 1 millimeter. So if that would have been the only concern, probably we wouldn't have gone to the OR again. But if you look at that tiny fragment, it's an anterior avulsion of the syndesmosis. It goes off to the front and it takes the fibula with it. And so the fibula is not aligned to the incisura. And this is definitely a reason to go there again. So, of course, you have to pull your pants down and go to the patient and tell her, well, it's not that perfect, but now we have a CT scan. We know we can do better. And then we went there again. And I think it's very crucial. Of course, if you like to do arthroscopy, you can also address this arthroscopically if the lateral incision is further up. I have a very small, very low threshold going there directly, have a direct look at the anterior plafond at the anterolateral corner of the ankle joint. Number one, because you see those syndesmotic avulsions, and here it was actually the case that parts of the anterior syndesmosis went into the space between the tibia and the fibula, and so anatomic reduction would not have been possible if that fragment and that parts of the ligament are not pulled out in the first place. And then, of course, you can see the lateral aspect of the talus. And as most of the osteochondral fractures that are acute injuries happen to be anterolaterally, so you will be able to see most of those. And of course, you can look far into the ankle joint to the other side. What you see here with the K-wire, that is poor man's navigation. So we knew the fibula was 2 millimeters out to the front. So we put the K-wire at the anterior margin of the fibula and then pulled it back and put the syndesmotic clamp on again. And we also tried to correct the medial malleolus. The syndesmotic avulsion was then fixed with a suture anchor. And of course, you have to show that you did better this time. And now you can see the fibula is nicely within the incisura, and the medial malleolus has been corrected. And so the whole ankle mortise looks better now. And this is the patient 3 years later. So the ankle mortise still looks good. Probably this would have not been the case with an unstable and incongruent mortise. So this is the anatomy of it. The anterior tibiofibular ligament is a very strong one. According to some biomechanical studies, it contributes most to overall syndesmotic stability, so more than the posterior ligament. And it has 3 strands, and some of the anterior strands may convert into a basset ligament after an injury and lead to some ankle impingement, but the most part of it has a big footprint on the anterior tibial tubercle and sometimes a little smaller footprint on the fibula, and it has significant resistance to external rotation of the talus in experimental fibular fractures, and also with just dissection experiments and the fibula being intact. So it is an important restraint for both the fibula and the talus. And of course, if you fix a fracture here, then you have bone-to-bone stabilization of the anterior syndesmosis, just like you have with smaller fragments at the posterior malleolus. So there's more than one reason to call it a fourth malleolus or malleolus quartus. And of course, there's nothing new under the sun. Also, the old guys who described those fragments, they thought about how they could have happened. Some of them did biomechanical experiments even before the advent of X-rays, like Thiel did. And they found that the anterior fragment, the anterior tibial margin fractures with external rotation, and some, like this guy Hönig-Schmidt from Innsbruck, already suspected that this is in fact a syndesmotic avulsion. And Chaput also suspected that abduction of the foot with respect to the ankle may lead to impaction of the tibial plafond. And I think we have some evidence now that this may be in fact the case. So going further in time, the Lauger-Hansen stations, there's a reason why the external rotation injuries have 4 stages. And so the first stage of every supination external rotation injury, according to Lauger-Hansen, would be either a rupture of that anterior tibiofibular ligament or a bony avulsion or fracture of the Chaput fragment. And when we go to pronation external rotation injuries, this is the second stage and happens after the medial malleolus fractures or after the medial ligaments, the deltoid ligament is rupturing. And likewise with pronation adduction injuries, the forces start at the medial side of the joint, and then depending on the force at the time of injury, it may lead to impaction. And of course, there's a lot of criticisms to the Lauger-Hansen classification and to the experiments. Nobody was really able to reproduce it. And now that we have CT scans, that we have videos, YouTube videos of people taking movies of their own injuries, we know that it's not always a fracture that looks, for instance, like a supination fracture, is in fact caused by supination. But maybe there's something to that abduction movement, and maybe there's something to external rotation. So when we looked up 140 cases that we had CT scans of with anterior malleolar fractures, we saw by far the most cases were avulsion fractures. And probably this is still an underestimate, because a lot of these injuries, if you don't CT them, may get overlooked because they are small fragments. There's overlap between the tibia and the fibula, particularly in the AP radiograph, and you probably don't see all of them. Second was an intra-articular fracture that all of them went both through the incisura and through the joint. So they are intra-articular fractures. That means if they are displaced, one should really consider fixing them. And the worst type of fracture were those with an impaction of the plafond. So probably these are transitional injuries to an anterior pilon fracture, just like in supination adduction injuries where there is impaction of the medial plafond. And in fact, when we looked up the Langerhansen stages as classified by radiographs, in our patient, we found that the type 1s, the avulsion fractures, were overrepresented in supination external rotation injuries, while the type 3 was overrepresented in pronation abduction injuries. So probably the old guys were right with their assumptions. And when we looked at ankles that had anterior tibial fractures and those who hadn't, we also found some interesting things. We found that patients were older with anteromalleolar fractures than those without. Probably at this stage, the bone gets a bit weaker than the ligaments, and so it's a bony fracture rather than just a ligamentous fracture, maybe. We also found that Langerhansen was right with his theory. We saw more external rotation injuries, and interestingly, we saw more pronation type injuries than supination type injuries producing those fractures. And we did not see a single supination adduction injury in all our 140 cases. And this is a diagram of that. So what to do with them? Of course, if they are not displaced and if there's no reason to go there, then probably you do not need to fix them. Once I am there and I fix a distal fibular fracture, I have a low threshold controlling seeing what the anterossyndesmosis does, if there's a small avulsion, and if there's something intervening in the syndesmotic space, I have a low threshold fixing it back with the suture anchor, particularly if it's a displaced one. The type 2s, if they are displaced, they automatically have an interarticular step off, and the incisura is not congruent anymore. So the fibula doesn't know where to go, as I've shown in those examples where it was still in a bad position after fixing the medial natural malleolus. So if they are displaced, they should be fixed. Most of the fragments are large enough to contain a screw, maybe with a washer, but depending on size and bone quality, and sometimes they are multifragmentary, also small plates can do the job. And here is my image with arthroscopy. Of course, sometimes it might be useful, particularly in those cases where there's an isolated fracture of the anterior malleolus, which is frequently the case in adolescents, where it can be considered a Salter-Harris type 3 fracture. But of course, it also happens in adults, maybe not so rare. We had 4% in our series that had an isolated anterior malleolar fracture, and they may be fixed percutaneously with arthroscopic control. And as you can see here, sometimes there's more to it once you look inside the joint than you would expect. Finally, those with impaction, I believe they should always be fixed because otherwise this will be unstable, the joint will be incongruent. And we saw some interesting cases in the session just 2 hours ago where this led to a valgus deformity of the ankle. And this can also, of course, lead to post-traumatic arthritis. Last but not least, it may be suspected, there's still not big proof about that, but it may be suspected that the avascular necrosis that can be sometimes seen in the anterolateral tibial plafond also has its root in an injury with impaction, maybe if overlooked, or maybe just the impaction that doesn't lead to a fracture, but to some bone marrow edema and maybe some disturbed blood supply in that region. So in that cases, we are generous to buttress this, lift up that fragment, put some bone graft, maybe from the medial malleolus inside, and buttress this with a plate. So now we have an example of a quadrimalleolar fracture where all the 4 malleoli are fractured. It's a 66-year-old female motor vehicle accident, so high energy injury, highly unstable. So he was first put into a frame, and then we looked up the CT images, and as you can see here, all the 4 malleoli are fractured. And then the question is, of course, what would be the best sequence to fix it? And so again, there's nothing set in stone about that. I like to, if there's a relevant posterior fragment that I like to fix, I like to start with that, because once there are no other implants inside, you can see the reduction, particularly if there's an intercalary fragment like in this case. So you can see the joint reduction, and typically once you do that, also the lateral malleolus already comes out to length a little bit out of most of the displacement, and typically only needs some fine adjustment. In this case here, it was a relatively high fibular fracture, also with considerable lateral displacement. We felt we put the plate from the lateral side, still with the patient in prone, and then finally put the medial screws in also with the patient prone. And then getting to the 4th malleolus, in those cases, you just add a tiny incision either over the Wagstaff fragment or over the Chapuis fragment, with either with the knee bend or just with the foot over a pad. And then you can get there and you can fix it directly also under direct vision. And then it doesn't take wonder, like with trimalleolar fractures, once you fix bony syndesmotic avulsions bone to bone, then the whole syndesmotic construct may be stable. I would still advise you to test it. And of course, this hook test on the X-ray only shows the lateral displacement that might be there. But of course, you should manually, above all, test the AP displacement of the distal fibula in those patients. In this patient here, it was stable. So after fixation of all the bony injuries, the syndesmotic complex was stable. This is the post-op CT scan showing the reduction of the 4 malleoli and the joint surface. And this is the patient 3 months later when he was putting on weight. Now, this is what we call a quadrimalleolar equivalent fracture. It's not the anterior tibial tubercle that is fractured. It is the Wagstaff fragment or the anterior fibular syndesmotic avulsion. As you can see here, the posterior malleolus has an intercalary fragment of considerable size that is carrying the joint surface. So this is another good reason to go from behind. So first, door is opened, never dissect the syndesmosis because that's what brings the stability. So I open the door, fix the intercalary fragment first, and then put a resorbable pin in, or just leave the K-wire and cut it flush to the bone as a lost K-wire, and then posterior anti-glide plate. Then the second step is the lateral malleolus, and in this case here, we did it via the same approach from posterior. And typically, there is not much work to do with the reduction. You have to be sure that it's nicely brought out to length and that there's no lateral displacement. And the posterior anti-glide plate, this has been shown many years ago by Artminoli and others, brings more stability than a lateral plate. And it brings the same stability, by the way, as a locking lateral plate. Then the Wagstaff fragment is fixed with a small anterior approach. And with a Wagstaff fragment present, you have to be careful that when bringing in the screw from the back, you do not displace this further. So it's wise to do this second small incision there right away and probably put a clamp on while bringing in the screws from the back. And then, of course, in addition, you can bring in a small screw from the front if needed. But now, in this case, this second screw from below is also holding the vaxxed fragment. And then in this case, the medial malleolus is fixed with the same medial approach that you would use with the patient supine and fixed with 2 screws. And again, takes no wonder that the syndesmotic complex at the end of the surgery is stable. These are the post-op radiographs, and these are the post-op CT scans of that patient. Here you can see the reduction of the posterior malleolus and that intercalary joint fragment. So we looked up the medium-term results, I would say 6.5 years after fixation of all 4 malleoli. So only patients that had an injury, a displaced relevant injury to all 4 malleoli, and we fixed all of them. And 17 of them really had an anterior tibial fragment, 6 had an anterior fibular fragment, and only 1 of those patients in the end, after testing the syndesmosis, was thought to require another independent syndesmotic screw. All the others were judged stable, and you see the results compare very well to bimalleolar or trimalleolar fractures in these patients. So what to do if things go wrong? Here you see a 30-year-old, so a young lady with a bicycle accident. She's very active. These are her initial CT scans. So CT scan was done after gross reduction and casting. And as you can see here, this is another quadrimalleolar equivalent fracture, but she was treated in the classical way. So just the fibula was plated and the medial malleolus was fixed with screws. And you can already see that here in the anterolateral corner, something is not okay. And resulting from this, if the mortise is not okay, then also it seems to be there's a medial incongruity. Well, it was not the medial malleolus that was incongruent. As you can see here, there was an unattended anterolateral fragment of the fibula. The posterior fragment was not fixed, so it was following the displaced fibula out of the incisura that had no stability to the back and to the front. So the fibula was rotated. The posterior fragment was going up, and the whole talus was tilting in the ankle mortise. So I agree this is not a horrible deformity, except maybe for the rotation, but it is a young patient, and this is now 2 days after surgery. So the question is, of course, can we do better? So we thought we can be, and we added a postermalleolar fixation just with screws and an anterior malleolar fixation with a small screw and another suture anchor. And then, of course, we have to prove that we really did better. So these were the pre-op CT scans, and this is post-op. And now you can see there is a perfect alignment of the posterior malleolus, a good alignment of the anterior malleolus equivalent. The fibular rotation is corrected, and there's no more spontaneous tilting of the ankle in the mortise. And one last case here, another active man, not biking, but motorcycling, which increases the amount of injury to the ankle. He comes in 2 months after ORF. He was told to gradually take up weight bearing, but he just couldn't. And so CT scan was done on him, and you can see several things. You see the posterior malleolus is completely out and following the laterally displaced fibula. So this alone results in an incongruent mortise, and you see the futile attempt to catch that fragment from the front. Maybe you can grab it, but you cannot reduce it. And also the stability is more than questionable in those cases. You also see the unattended anteromedius equivalent, so that wagstaff fragment. And of course, you see the malrotation and inversion of the distal fibula. So here you can see the same things, posterior malreduction. They even managed to catch that fragment, which is okay, but they didn't reduce it and fix it. You see the unattended anterior fragments. And you can see that even the fibula is not well reduced up there. And even the medial malleolus doesn't look very nice, but we did not dare to go there because of that skin necrosis. So we started all over. We started from the back with the posterior malleolus, with the dorsal anti-glide plate. We redid the fibula with the locking plate this time, bringing it back to the front, and then the anteromalleolar correction with a small anterolateral approach. So this was done with the patient lying in a lateral decubitus position because we did not venture to the medial malleolus. Of course, you can also put the patient in a somehow floppy lateral position if you really need to go there. We tried to push it a little bit, and then we thought we were with a stable ankle mortise. And in this patient, I felt it would be better to also do a temporary fixation of the syndesmosis. So we did in this, because it was an old case, we did a hybrid fixation. So when the screw breaks after the patient takes up walking again, then he still has that flexible implant further up that still holds everything together. So this is the result of correction. Of course, the bone doesn't look very well after he is now 16 weeks without weight bearing. So he had to take up weight bearing again to heal and to get back to work. So my conclusion is there are 4 malleoli around the ankle, 4 pillars that we have to respect. The anterior one has more in common with the posterior one, even though it might be in most occasions a bit smaller. And if displaced, and particularly, of course, the larger it is, the more impaction it is, if there's any joint impaction, it should be addressed. And if you'd like to read more about that, there's another American, Indian, German cooperation on that. Thank you very much for listening.
Thank you, Stefan. I hope you can hear me. Great presentation, actually. I loved your, apologize, I got the hour wrong, I think, and I logged in late. Yeah, fabulous. We are thinking about the malleoli around the ankle, but, we do have problems. Whenever we have ankle trauma, there could be fragments within the ankle too, right? Within the ankle joint. Several other authors as well have done arthroscopic diagnosis of fragments we see within the ankle, in addition to 360 degrees around the ankle. Congratulations on the lot of great work you did in the anterolateral fragment. Just one quick question, then I will start sharing my screen. The question is this, obviously the fragment you can see on x-rays or maybe a CT scan, but what happens if it did not avulse the fragment, but, ligament has ruptured in the anterolateral, anteroinferior ligament. Obviously it can be tested during intraoperative fixation. Hopefully it will show up. But if you're doing syndesmosis screws, you may miss that. Do you now advocate doing something to the ligamentous? So if the ligament has ruptured, what would you do? The anterior inferior tibiofibular ligament. If it avulses fragment of the fibula or the tibia, you can know, but on a CT scan or X-ray. But what happens if you don't?
Well, definitely it depends on if it's the only ligament that's ruptured. If it's only the anterior ligament, then the syndesmosis will still be stable. And so I think this is what we see frequently in the classical Weber B fractures, the what we consider supination, external rotation, stage 2 or 3 injuries. They are displaced. We fix the fibula. The syndesmosis is stable despite we see the ruptured ligaments with our own eyes there. Still, in those cases, I have a low threshold looking at the anterolateral aspect of the joint. Number one, to look for interarticular fragments, as you rightly point out. And number two, to see if those anterior ligament ruptures at the syndesmosis, if they somehow intervene with reduction of the fibula. And then, of course, you have the Maisonneuve type injuries, where there is, of course, gross syndesmotic instability. there's a minimum of two fragments, ligaments that are ruptured. And so it must be unstable. In those cases, I will always have a look at the anterior syndesmosis before putting the screws in, so while reducing it, to really see that the anterior tubercle of the tibia and fibula are well aligned, to see at that corner, the anterolateral corner of the joint. There are some nice studies out there also from the United States that looking at that alignment and palpating the anterior margins of the tibia and fibula, that these are the most important things to avoid malreduction. I think we learned it the hard way when doing post-op CT scans. And luckily now, rarely in post-op CT scans, we find some malalignment because we learned these lessons. So I think it's very important to look at those things. And of course, once you're there, you may, in addition, once you fixed the syndesmosis with a screw, you may, in addition, put one or two sutures through that ligament. I don't think it makes a lot of difference. The ligament has to be in a good position to heal, just like the lateral ligament and the deltoid ligament in ankle fractures. But if for some reason you cannot reduce the fibula, then you should be suspecting that there's something intervening, and this might be a ligament, or it might be a small chip avulsion of the bone.
Great job, Stefan. We came a long way trying to understand these fractures. We've been fixing these fractures for many, many years, and we're still learning, with the aim, obviously, to improve the outcomes. I don't know how much time I have, but I'm going to quickly run through some of my experiences with arthroscopy in ankle fractures. Are you able to see my screen there?
Yes, we can.
Okay, perfect. So, I don't know whether I should put a presentation mode or, but then I can't see myself. Anyway, so here is the fractures. You can see, traditionally, these kind of fractures, the low, very distal lateral malleolar fracture and a very wide gap, wide opening on the medial gutter.
Vinod, hey, hold on one second. Hey, Matt, can you let me know, is this visible to everybody?
Yes, it is.
Okay, go ahead, Vinod. Sorry.
Okay, all right. So then you see, this is where I got into ankle arthroscopy. I don't know whether I can do presentation mode. Let me, let me see presentation. Oh, it's actually taking me off, but hopefully you can still see. So what's happening here? You see, this is intraoperative, my attempt to reduce, the medial gutter, medial space. I wanted to see if I can congruently reduce it. We're not able to reduce it. So you can see what's happening is there is an obstruction. I did a scope and I found there's a big fragment. This is the medial gutter we are looking in, and you can see is a large osteochondral fragment which is obstructing the reduction. So once we reduce this, and there is a lot of deltoid ligament completely disrupted as well. And you can see before removing the fragment and after removing the fragment, you can see the reduction of the medial gutter. And again, corresponding fluoroscopic shots before and after removing that osteochondral fragment. So here, arthroscopic intervention was really helpful for me to get the reduction going. Then obviously, once we get that done, we can put a plate on the fibula and get that. And then, like we've seen Professor Rammelt also do this hook test. It only shows lateral displacement, does not show anterior posterior displacement. So, but the point is that, we can actually use our ankle arthroscopy to diagnose, what is actually holding the reduction back. At that stage, I actually started opening the medial side, and a deltoid ligament was ruptured. So we put suture anchors and wanted to make sure that it will not displace in the postoperative healing period. So we put suture anchors, and I know increasingly folks are, jumping on the bandwagon of repairing the deltoid ligament. I used to be one of those folks who never repaired deltoid ligament, thinking that we could either reduce the talus and the mortise by syndesmosis fixation or anterior and posterior fixation. But sometimes if the deltoid ligament is completely ruptured, I think to guarantee that it will not displace subsequently, increasingly folks are using deltoid ligament repair or deltoid ligament stabilization, I would say. Now, this could be done open. Now, increasingly, we could do this with the scope itself. I will show you some examples later on. So this is the 6 weeks follow-up. You can see the talus has not drifted off, but many occasions I have seen if we do not stabilize the deltoid, they can go into a lateral displacement and have later problems. So, I feel that if you do not do anything to the deltoid, we should at least hold these ankles in inversion or make sure that the medial gutter does not open, or you do internal stabilization like we did this before. So my feeling is that deltoid ligament should be fixed. Here is another example, especially if they are widely open. So this is the example was done, somebody else fixed this, you see. So thinking that the syndesmosis screws can actually stabilize the deltoid, but as you can see in the post-operative follow-up pictures, this does not happen. When the deltoid ligament is completely disrupted, you leave instability, and then the talus can actually drift off. So I think it's a good insurance policy to make sure that you have something to stabilize on the medial aspect. So if you're not doing an operative stabilization of the deltoid ligament, you cannot actually use the cast and inversion. This is another example. I'm collecting quite a few of these, and again, the quadrimallular fixation was done here. You can still see this opening on the medial side. So we went ahead and repaired the deltoid. This was done by open method. Now we are increasingly doing this with the arthroscopic methods. So I'm going to rapidly go over to the arthroscopic methods because that's the focus of the session here. So you can see, again, this is another example. Deltoid was not fixed. As you can see what happens, they will come back later on and then have incompetence. So that we focus so much on joint congruity, reduction of bony fragments, but we leave alone sometimes restoration of ligament stability, hoping that it will heal. Syndesmosis, we got better by stabilizing it either by screws or by some flexible fixation methods, but deltoid, I think we should all pay more attention so that it does not drift off and cause later on problems. So I started doing this deltoid ligament repair, and then got more and more into doing this arthroscopically. This is a cadaver lab and experimenting with different, you can see the, different suture anchors and so on and so forth. You can see a synthetic ligament between the tip of the medial malleus and the lateral aspect of the, medial aspect of the talus. And we open this up, and this is the medial side. We can see the suture, the synthetic fiber tape in there, and we wanted to see how strong this is. And you can see I'm trying to attempt. This is location of the. I don't know whether you can see my mouse or not, but this is extra-articular. You can see the medial surface of the talus here, and you can see the footprint of the suture anchor over there. And now I don't know whether this video will play. Yeah, see that? That's the stability I have. So what I'm going to be doing in the next video here is, get my assistant to cut that ligament which we repaired. Okay, so you see now my assistant will cut that the synthetic stabilization we achieved arthroscopically, and then you will see how immediately opens up. There you go. See that? So the sound effect as well. So, we can certainly achieve that stabilization through the scope. You can see there's a fragment within the medial gutter. And again, what do? You can do everything else, bony, but I think we can add ankle arthroscopy to our armamentarium to help us do the best we can to reduce this. This is, again, another fragment within the ankle joint. We removed that. And then, we got the reduction there. This is all arthroscopic. So now I'm stabilizing this medial instability or deltoid ligament stabilization using entirely a smaller incision and through the scope. So you can see this is the ligament placed between the medial malleolus. I don't know if you can see the mouse or not, but you can see that's the medial malleolus, that's the talus. And I have a insurance, I have a guarantee that the talus will not drift off. So at least I'm allowing the deltoid ligament to heal well. And these are the portals. This is the trauma, and my portal is here and here. See, so this is a standard portal, and then this is one for the suture anchor introduction. And they do well. This is the previous X-rays. Once you stabilize this, the talus doesn't move. And then you can do your rest of the fixation. And this is another example here with the scope. You can see the wide, big gap in the medial side. That means that the deltoid ligament has gone. I mean, you don't even have to do anything else to know that. So again, you put suture anchors. You can see arthroscopic pictures. This is post-deltoid repair. I'm stressing it. It doesn't open up. I put everything else. There's a flexible fixation over here. And this is a follow-up, 6 weeks. I can sleep well at night thinking that the talus will not drift, not at 6 weeks, not at 3 months, not at 2 years. So I think if we stabilize or repair the deltoid or do whatever you can, this is my team. And I think I just wanted to emphasize the point that arthroscopy has a lot of uses, and then you can certainly use it not only to detect the fragments and reduce the fragments, like Professor Rammelt has showed elegantly in his talk, but also diagnose ligamentous injury and stabilize the ligamentous injuries as well. I think we are close to the hour. I want to thank the great Selene Parekh. I don't know how he does this. He must be caffeinated to the fullest extent, but he does a tremendous job, and he did a great job in India and also now abroad, everywhere else in the world. And I appreciate him giving me this opportunity to share what I'm doing these days with ankle arthroscopy. And if there are any questions, I don't see the Q&A here. But if there are any questions, I'm happy to answer them.
Yeah, we have 2 minutes.
2 minutes.
So, are any questions? I don't see anything in the box. Actually, nope, I don't see anything in the box either for questions.
Thank you.
So,
thank you, Selene, for the opportunity.
Thank you so much, Stefan
Yeah.
and Vinod. Really appreciate the insight and the knowledge.